Okay. Go.
Okay, so we have Stephanie Oliver doing her 12-lead ECG interpretation. Her student number 15917495. And you're allowed a minute to write down the steps, if you wish, of an ECG.
Okay.
I'm going to hand you an ECG if you could read out the number of it, which is on the bottom.
Okay. Number 4.
Right. And I'm just going to give you a short history.
Okay.
I have a 56-year-old male playing tennis. He developed sudden central chest pain and vomited. Conscious collapse, witnessed, non-injury. An opponent called the ambulance. The patient is pale and sweaty. He'd been playing for 20 minutes and he has 7 out of 10 chest pain.
Okay.
Start your assessment.
Okay, starting now. Okay, so having a look, I'm just going to do general impression. Carousel pony looking in V2. And it's quite fast as well. My R wave progression is early, also in V2, should be in V3. And my tachyr, so calibration spike is 0.20 seconds wide and 10 mil high, which is normal. I've got no frequency response, which should be 0.05 to 150 hertz. Don't have any of that. No paper speed, which should be 25 mil per second. So I've got no name, no date, no how the patient was feeling or anything written on there. There doesn't look to be much artifact. I've got a negative AVR, which tells me that the leads should be in the correct position. And yeah, that should be my tachyrs. Right. I'll go for the rate now. Let's see if it is regular. And I've got a QRS in every lead, so that is good as well. Okay, my rate is normal, so I can use the 1500 method. I count the number of small squares between two R waves. So 5, 10, 12, 13, 12. So the 1500 divided by 12 is 125 is my rate. So it's a bit fast, over 100. So then I'm looking for P waves. Yes, I have P waves. They are symmetrical in 2. A bit biphasic in V1. So that is an intraatrial conduction delay. But there is one for every QRS, so we're going sinus tachy for our right. And then we're looking for our PRI interval, which should be between 0.12 seconds and 0.20 seconds. And regular, which they are, constant at about 0.20 seconds, so they are not prolonged with no heart block. Yeah, they're sort of right on. Okay, so no heart block there. Q waves. Do we have any Q waves? Little baby Qs in 3. And AVF, they don't meet the criteria of being more than 0.30 seconds wide or 1/3 the height of the R wave. My QT interval, because we're at a regular rhythm, I can go the half RR rule, which it's about right on halfway, maybe a little bit less, so we don't have any QT prolongation there. My QRS complex, I'm looking for it to be less than 0.12 seconds, so normal 0.06 to 0.11 seconds, which it is not wider than that. It is about 0.11 seconds, which is normal. My ST segments, I'm looking for elevation or depression, greater than in 1 mil in contiguous leads in the limb leads, which I do have elevation in 2, 3, and AVF. So I'd want a V4R to look at reciprocal changes. Oh, yes, I would want that, but I'm looking for reciprocal changes in 1 and AVL, which there is some in AVL, so I'm quite certain that we have inferior. Looking in other leads as well. So we have quite significant depression in V1 and V2, so I'd want a posterior ECG as well to look at reciprocal changes for that. And I do have elevation in the lateral leads as well. And then the T waves, they should be asymmetrical, and they should be positive, and they shouldn't be more than 2/3 the height of the R wave, which they're a bit peaky, a bit high, so we're definitely seeing some signs of changes there. As for the morphology, we've got no wide QRS. We don't have any bundle branch blocks. And then hypertrophy, we're looking for the Sokolow-Lyon criteria, so add the R waves and the S waves need to be greater than 35, which they are not. In V1, V2, V5, and V6, needs to be greater than 12 in lead 1, 11 in AVL, and 20 in AVF, which we don't have. And we don't have a positive in V1, so we have no hypertrophy. No axis deviation. Lead 1 is positive if the thumbs method, and AVF is also positive, so I'm thinking normal axis, but we'll graph it out just to be sure. 1, 2, 3, 4, 5. So we've got 5 over to the right, and then AVF is say 5 minus 1, so 4. So 4 down because it's positive. So I'd say that's about between positive 30 and positive 15 degrees. Oh, wait, right on 30. We'll say 30. We'll say 30 degrees axis. What's the normal axis? And we have a bit of the smiley face for our STEMI, non-STEMI in the inferior leads. So interpretation will be sinus tachycardia is the underlying rhythm. We've got an intra-atrial conduction delay. Looks to be an inferior posterior STEMI with lateral extension. I'd like to get a V4R and a posterior ECG to confirm.
So your posterior ECG, you see 2 millimeters of ST elevation in V7 through to V9.
So I'd say yeah.
And for V4R, you see 2 millimeters of ST segment elevation.
Okay. Well, and he's a 56-year-old male, so you need more in the, well, V2 and V3, you'd need more than 2 more of elevation, which you've got. So, yeah, inferior posterior STEMI.
Right, that's your interpretation.
Yes.
So there's a couple of questions now. First one, what arteries are likely to be involved if this person has right coronary dominance?
The inferior would be right coronary artery, and then the laterals would be the left circumflex, and then the posterior would be the PDA, posterior descending artery.
All right. The second question, what are reciprocal changes and what do they show?
Reciprocal changes are the mirror image of what you're looking at, so they just sort of confirm what you see on here from a different angle. So if you see elevation, when you look in the reciprocal leads to that lead, you should see depression. Let's see the mirror image, exact opposite.
Okay, that's the end of the questions, end of the recording.
Bye.